Good morning, everyone. Thank you. I mean, let's talk about sort of what are clinical trials and what are the outcomes that people want to see, and what are the priorities from both sides. So we'll maybe talk about that a little bit. Okay, so I mean, going into a clinical study, I get often asked, am I a guinea pig doc? And I say, well, no, actually, because we know that these treatments already work, but it is very much stepping into the unknown for many people. So, this is the joke, the devil is pushing this guy, come on, which door do you want to go down? And it's like a randomization in some ways, so it's a stressful time. Now, this is old data, so I mean, I'm old enough now to have a bit of history and to sort of see the perspective on things. And I remember this graph being shown for the first time when we were starting to work out what could we do with CLL that rescued these bad vertical lines and make them turn into good horizontal lines. So how do we get from here? Well, what we did then was, okay, well, let's just push things a bit harder. Let's give more chemotherapy. Let's throw in combinations of drugs and make life more toxic for the CLL cells so that we can really get rid of this disease. So we went through this process a number of years ago of just pushing things harder and harder, but we knew deep down this is not the answer. And we were searching for that elusive biology of the disease that opened up new territory. So the penny finally dropped. We didn't realize that these CLL cells were manipulative, junky cells, shooting up on B-cell receptor signals, manipulating the microenvironment around them. And we can step in there and make them go cold turkey now without using this combination of chemotherapy drugs. So we go from there to here, and here. This is some interesting data, a bit like the UK data. This is a study that was shown at ASH last year, Anders Osterberg and the Swedish experience, essentially showing that ibrutinib compared historically with a broad range of previous chemotherapies was outperforming this, and indeed that good horizontal line was approaching that of the normal Swedish population. So moving in a very different direction. So what is a clinical trial? This is a fairly simple schema which makes it look as though this is going to be very simple, quick and cheap to set up. Now we understand from our colleagues in pharma that actually it's an incredibly slow and expensive business, and we know ourselves that when we're trying to think as a clinical trials group, what is the correct answer, correct question to answer here? What is the correct drug combination? What is the correct demographic for this trial? Then that's not an easy thing to do, but eventually, by hook or by crook, we get an approved protocol. We go, okay, yes, we've got a sponsor, we've got a combination of drugs, we've got a question, and we've got some funding and backing behind it. Okay, so let's do that. So everyone then goes back to their centers and says, I've got this protocol. I'd like to have this as a clinical trial here in my center. Can we do it? So I go to my committee and we all look at it and say, yeah, that's a jolly good trial, let's do that. Or they'll say, no, that clashes with this one, we can't do that here. So that can happen. But let's say it goes to our Institute Review Board, the ethics committee within the hospital, filters down through the R&D department, and then after a variable period of time, which can be frustratingly measured in months frequently, we're then told, okay, we can do that. And then we start recruiting our patients. We give them the patient information sheets and say, I'd be interested in your views on your treatment. Where should we go? What would you like to do with your therapy? What are the goals that you would like to achieve with this? Does this clinical trial offer you a vehicle to achieve your goals? Have a look at this. And patients often assume that once they've signed on the dotted line and given their consent for a study, that it's a no-brainer, they're in, and they're off and running within the next couple of days. And it often doesn't happen like that. So in terms of signing a consent form and actually enrolling in a study, there are a number of pitfalls, including eligibility, so whether somebody is going to fit into the study, or whether in fact that bowel cancer that they had 2 years ago and renders them ineligible for the study. For example, or maybe they've had a hepatitis virus, or maybe they have HIV, or maybe there's something else. There's some kind of comorbidity which excludes them from the study. Or they have disease progression before they can start and they become too unwell. So if you have to have a performance score of 2, and i.e. up and around more than half the time, and they become unwell, then suddenly they can't go into it. And they suddenly can't have that treatment. So it's not a done deal until you start. So starting to get patients into studies, again, is another hurdle. And then we've got the process of data collection with employing and recruiting the data management staff, the research associates that we have in-house, and the people who come down to visit us, and then a bunch of statistical analysis that's going to occur over a period of time, culminating in the presentation of these trials at national, international meetings, and then a publication, usually simultaneous at that stage. And then if there's a positive result, that's great. That may lead to drug registration, and then once it's approved, is it going to be funded? And then there's the whole angst of, have we got money to support this drug? Does our country, does our nation have the wherewithal to use this drug? So it's not a simple process at all. So what are those considerations in trial design? Well, we talk about endpoints. We talk about primary and secondary endpoints. And within the study, basically we're saying, how intensively should we treat this population? What is the right population for this study? What is progression? So we talk about progression-free survival, we talk about overall survival, and progression-free survival is something that we've used a lot in CLL because we know that people will have one treatment, another treatment, another treatment. As Chris says, maybe 6, 7, or 8 treatments, and we've seen this in the past. So progression-free becomes a surrogate marker for how well people do. And time to next treatment and progression-free survival is a very, very important outcome for our patients. But if we're looking for cure of CLL and overall survival, then those are other matters. And that might influence how intensive the treatment is going to be in the trial. And there may be other endpoints, such as this minimal residual disease assessment, where we look at the blood or the bone marrow, usually by flow cytometry these days, to assess how much or how little disease there is and see whether it goes below the detectable limits of the current technology. And we know that if it goes below those detectable limits, actually those people do better. So it's becoming an important outcome in clinical trials. In terms of quality of life, we must maintain the patient at the heart of the whole process, because if the disease is better, but it's a shame about the patient because they're struggling with all the toxicity of an inappropriate treatment, then, what have we achieved? So how do we factor in that comorbidity? How do we assess how fit people are, how unfit people are? I'm going to talk about some of those tools that we use to measure comorbidity and fitness. And what about those side effects? Well, there are processes within clinical trials that monitor toxicity, and there's usually a data safety monitoring committee which assesses this on an ongoing basis to say, no, it's okay, it's all right, these people are doing all right, they're not suffering too much, we're weighing it up, and there's the index of, what should we call it, worthwhileness, an expediency index. It's still there in the balance, it's looking good, or it's looking bad, we've got to stop the trial. And trials do stop because of toxicity. So there are concepts in biology and treatment that are changing the nature of our studies now, really challenging what it is that we do. So one of the issues that we have now in clinical trials is, what do we use as second line in a study? And if it's a really powerful combination of drugs, or it's a less powerful combination of drugs, we could find that one of our clinical trials suddenly becomes irrelevant. I mean, we don't want to run a second line study of chlorambucil now, or of some kind of antibody drug combination that's going to be less effective than some of the novel agents, because as a second-line trial, by the time it gets to the end of it, we're going to say, well, that was worthwhile, wasn't it? There's nothing there. We don't learn anything from that. So we've got to be careful about what are the trials we do and when, whether it's first line or second line. So structuring that intelligently becomes very important. So the challenges might be in defining those endpoints and understanding patients' priorities and how we refine those priorities, how we articulate our patients' priorities. Now, I was reading through some of the abstracts in the ASH website, and buried down at abstract number 1239, there's an interesting study where a patient group from New York is being asked the question, would you have treatment A or treatment B? Okay. So treatment A is an intravenous treatment. You have it over 6 months. There's no diarrhea. 15% chance of a serious infection, grade 3 infection, that's going to land you in hospital. 8% organ damage. But your progression-free survival is going to be 26 months. Okay, 26 months. 6 months of treatment, 26 months progression-free survival. Or you can have treatment B. Treatment B is a tablet. You're going to take it for 5 years. There's a bit of diarrhea, but your progression-free survival is also 5 years. But there's a 30% risk of a serious infection. What are you going to have? There's no money involved. What are you going to have? So 91% of respondents said, do you know what? I'll take that tablet. I want to go for 5 years. I'll take my chances on that infection risk. I don't mind a bit of diarrhea. I can control that, okay? So what if it's going to cost you $75 a month to do this? Well, it suddenly changes and it goes down to 50-50. I can't afford $75. 26 months, that's all right. Yeah, I'll weigh it up. What if it costs $400 a month? Well, suddenly it's 75% off for the 26-month progression-free survival. So there's a sliding scale of priorities that our patients are going to have, which goes beyond health considerations and involves the wider sense of their family. If I'm spending $400 a month on this, I can't afford to do this with my kids. I can't afford my wife, my partner, whatever it is, to have this other treatment it might be, because I guess people are going to be, as couples, we're getting old together, right? So there's going to be considerations of looking after my spouse. And I can't afford to do that if I'll go for the 26. So there are considerations there, and these are important. How do we identify that? How do we locate and articulate the priorities that our patients have? And then how do we communicate that? How do we communicate that to pharma? How do we communicate that within our clinical trials committees? And how do we take it out to specialist clinical groups and say, this is what people want to have? So we're balancing the quality of life, we're balancing that with these harder endpoints of MRD. So it's okay, I can tub thump and say, we've got to treat everyone to MRD. But is that what people want? Okay? It may well be, because it's an important endpoint. So what are the limitations of a clinical trial? It could be slow to recruit. Okay, you try and sell something. Well, I'm a salesman. Okay, that's what I am. I'm a salesman. I sit there with my patients. I'm going to sell you some treatment, and I want you to have this. Okay, and my patient will look at me and say, "Are you mad? I don't want that. I'm going to have this instead." Okay, so I have to be a good salesman. But no matter how good we are, if it's not the right trial, it won't sell. If it's the wrong treatment, it won't sell. And what depends on the expectation. So here's the Galactic trial in the UK, which is closing when? Today? Yesterday? Tomorrow? Something like that. It's closing. Hasn't recruited. And this is all about giving obinutuzumab for people who've had a response after treatment. Can you consolidate the therapy? Can you drive people into an MRD undetectable state? And will they do better? And for whatever reason, people say, well, I'm in a remission. I don't want anything else. You said that was it. I was going to have a bit of monitoring. I don't want to go back. Do I need this? No, you don't really need it. So no, thank you very much. And it doesn't recruit. So it's about building in expectation from the start, about creating an expectation that actually MRD might be a valuable thing to achieve before you start your initial day one therapy. So if you've had the prescience to do that, then it becomes easier to sell the concept at the end of therapy. So for whatever reason, that hasn't happened and the trial has collapsed. So it hasn't recruited and you can't do it. So a clinical trial may not see the light of day. Or it may not reflect the normal population. So we've got a whole bunch of people in this study that tells us that 99% will respond well with no toxicity. Wonderful, what a great treatment. Okay. But is that the population of people that we're actually treating with that drug, or is it just the clinical trial population? And we know from experience that this is the clinical trial population that may not reflect our patients. So how do we normalize things and say it's normal to be in a clinical trial? Come and join us. The more people we have, and the wider the range of people in this study, the better that result is going to be. Now, it won't be statistically different in the way. You're going to get a different answer, but the power and the endpoint and all the other parameters around the study, that doesn't change. It's just the population of people within the study that makes it more real. So we know that as people get older, we start accumulating problems. We get our arthritis and our blood pressure and our diabetes and all the things that human animals get. Aren't we lucky? So this, on the maroon at the top, on the right-hand side, our over 75 population, they've got more than 5 problems, 5 medical problems. And, and this is very common. And what do we see in the CLL clinical trial population? Well, we haven't seen any of that maroon. What we have seen is that purple bit at the bottom, that tiny little band of no comorbidity, suddenly expands into, hey, we've got these really fit elderly people that we're going to put into the clinical trial because they can. They're the ones that get through the eligibility criteria. They're the ones that have jumped through the hoops. And they're the ones that haven't had bad disease and have got good performance scores and are able to get through from signing a form and giving consent, or even being able to read the information sheet and moving forward and receiving the therapy. So we're selecting our patients for fitter people, even in that elderly group. Okay. So there are various different ways that we measure this fitness and frailty. Validated studies, validated tools, as they're called, to assess quality of life, fitness, overall health. Okay, so it doesn't matter what they're called, EQ5D, QLQ, CLL16, so a specific CLL questionnaire to assess how far you get on. I like this one. This is the up and go test. You sit someone down and you say, okay, sit here. I want you to walk 3 meters, 10 feet, turn around, come and sit down again. You know, you take that for granted. You know, we're all of us here, we're going to jump up and go and get coffee in a second, but do we spare a thought for how simple a test that is of how fit someone is going? So we use this up and go test. Lots of questions that people fill out. Have you had a bit of a cough? Do you bruise easily? Have you got any skin trouble? Itchy skin? Do you feel slowed down? So lots of different questions, breaking this down. So this doesn't come back to me, but I'm aware that my patients are filling this out. So I kind of got interested in this, and I thought, what are they actually saying? What are my patients saying when they fill this out? It's difficult information to access. Here's the cumulative illness rating scale, the CERS score, which you may well have heard about. And this is easy, sort of, if you've got a 0 score, then you have no comorbidity. So you don't have heart disease, there's nothing there. You don't have joint problems, you don't have skin problems, eye problems, hearing problems, psychological problems, all sorts of things. So it's actually ever so easy to accumulate a few comorbidities. And, many of us in the room, including me, I've got a CERS score. I'm not going to tell you what it is. But we all have a CERS score. And it's a little bit subjective, right? The severe stuff is easy to measure, and the 0 scores are easy to measure. It's the stuff in the middle. There's a bit of a gray zone. And we know that our patients with CLL, there's a broad combination of these CERS scores in there. So most people will have some comorbidity. And look at this, 4, 5, 6, 7. These are the normal amounts of problems, cumulative problems, that people will have. So they're on treatment for one thing plus another thing. They have a score. If we look at first-line therapy, this is some data showing just under 2/3 of people who had FCR have no comorbidity, apparently. So our challenge then is to encourage that trial enrollment, to get the right demographic into the studies, to familiarize patients with these quality of life tools. And would that actually be useful for people to know that these exist before they go into a trial? How early on in a patient's career would it be helpful to do this benchmarking and self-analysis and self-awareness of what my comorbidity is, and to start using that vocabulary? I'm sorry, it's flashing times up, but I think I started late. Okay, so just before you stand up, Nick, where you would have stood up by now. So, is this something that we can use to encourage people to be aware of their health? So here we go, going back to this group, and I started rifling through this data in a slow-grow group of people. So these more elderly, less well group of people who I wanted to know how well were they doing? What do they think of themselves? What do they think of their health? So a group of 23 patients in a couple of chlorambucil, bendamustine-associated therapy combinations, right? They had a median SIRS score of 6 with comorbidities, high blood pressure, diabetes, COPD, a bit of chronic kidney disease, some depression, some had previous skin cancers, bladder problems, somebody with multiple sclerosis, peripheral neuropathy, a whole range of things in there, a lot of joint problems, as you'd expect. And they benchmarked themselves. They used this VES 13 score to benchmark themselves against Doris, who lives down the road. They eyeballed their next-door neighbor, also a median score of 82 years of age was the median age in this. So, I'm 82, she's 82, how am I doing? And we found that our patients actually rate themselves as pretty healthy. Okay? Pretty healthy. I'm doing okay. So more than half, 2/3 of my patients said, I'm as healthy as anyone else. And some of them said, I'm doing better than she's doing. Look at me, I'm coming in and out of the hospital, I'm going off for my game of golf, whatever it is. So they actually rated their health as, so this is high risk. So they've actually, my 82-year-old patients have got a lot to lose. They've got a lot of health to lose because they rate themselves as pretty healthy already. And that's important. So they stand much to gain, and that's how we sell it, but they also have much to lose. So what is it that they've got to lose? How can we articulate that on their behalf? And here's the bottom line, okay? The bottom line is, how long are we going to live? Because life is precious. When you're 65, whether you're a man or a woman, and it's a bit better for women, we're going to live another 20 years. So we're going to live from 65 to 85, whether you like it or not. But the problem is that only half of those 20 years are healthy. The other half are unhealthy. This is where it all catches up with us. So we're going to have 10 years of struggle. Okay? Now we're picking up our CLL patients somewhere in there, maybe before they go over that into that 10 years of ill health, or maybe during those 10 years of ill health. And that's where we pitch what trial might be right for them, for example, and how they could. Okay. So we've got these data safety monitoring committees. Can the advocacy groups collect data of those comorbidities, of those toxicities? Can you shadow this process of the clinical trial? Is that possible? I don't know. Is it desirable? I don't know. What about concomitant medication, the medication that you get or you should get when you're in a clinical study? Okay, we had a problem this year. 2016, we had a problem. Why did Idela drop off? Because we weren't giving our patients PCP prophylaxis or screening for CMV. We knew this stuff. Okay, we're all responsible for this. It's easy to point fingers, but we're all responsible for this. And the other thing is, well, I never heard what happened in the end. You know that trial I was in, Doc, what was it called? Watch and Wait study, or whatever it was. I never heard that. Rialto trial. What was it? What was that Rialto thing? Something about Venice, anyway, I can't remember. So how do we get those reports, digestible reports, back to our patients? Can we build that in from the start? Can we challenge the trial organizers to actually say in the patient information sheet, I don't think it's in there. Correct me if I'm wrong. Is there something in there to say, this is how we're going to get the information back to you? This is how we're going to do that. People want information back from studies. So I think this is my last slide now. So prioritizing life expectancy versus quality on that sliding scale that we talked about, thinking about the health economics for the individual in their own personal circumstances, empowering people to say, can you tell me what clinical trials you've got in this center, or who else down the road has got something that I might be interested in? Encouraging an awareness of concepts of health, using the vocabulary and learning the vocabulary of comorbidity and things that people don't often think of using before they get into a study. And maybe there's this opportunity in older patients to say, actually, once we've scooped you up you're in our tractor beam, and you're before those 10 years of severe comorbidity, maybe we can help our CLL patients to be healthier than they otherwise would be, than the other half of humanity that aren't in that CLL watch and wait group. So there's a bit of a challenge. Can our CLL patients actually live longer and do better than normal population? We might be able to do that. Anyway, thank you.
So we have a few minutes for questions, and I'm going to start with a question for Dr. Kennedy, and that has to do with the arms of a trial. In the past, it seems like their trials have been designed to make it as easy as possible for the new combination. So they've really picked a straw man like Carambasol or something that's easy to knock over. And I wonder, and I heard Dr. Fegan talk about that being unethical in one trial where the comparator was rituximab. The second part of that trial is from a patient's point of view to show overall survival data. That means people in one arm have to die. That's the only way you can show. What about crossovers? I know that it messes up the data, but how do you ethically address the issue if you see that one arm is doing better than the other? How do you not allow a crossover? How can a trial be designed without a crossover? If you could comment on that, or anybody else want to comment on that? Yeah.
Yeah, I'm personally responsible for all this, of course. No, I'm not. I think we see our patients, if they're in a study and the treatment isn't working, then on an individual basis. I mean, you see the graphs, and that represents a group of people. That's the herd effect. But on an individual basis, if something isn't working, you take your patient out of that treatment, and we don't have to continue with something just because you're in a clinical trial. We're not beholden to anything, and you give them treatment that's going to be more effective for them. And if there is a crossover in the study, then being vigilant about how they're coping and tolerating and responding gives you the opportunity to make sure that crossover occurs at the appropriate time point.
But some of these treatments are only available in trial, so if you don't have the crossover built in, I mean, some of the reasons people enter the trials are to get to the new drug free.
So, I was going to say, in fact, it can happen before that we treat outside trials. Okay, I'm not saying that this is good practice, but it is tempting to treat somebody outside a trial with an ineffective drug, knowing that that's going to trigger something because they will almost certainly progress and then be allowed access to that clinical trial or a treatment that is approved and funded, which is going to be more effective. So the risks there are that you're doing something which is potentially unethical to give a drug that isn't going to work so that you can get access to a drug that is going to work. How crazy is that?